Well, hello and good afternoon to everyone. We are super excited to be presenting this webinar with you all. As you all know, we are in 2025. So with that comes new coding and regulatory changes for us to discuss. And I'm super excited that I have the honor to present them all to you this afternoon. So thank you so much for joining, no matter where you are in the world. Thank you so much for joining. We do appreciate it. So as I mentioned, well, I didn't mention my name. My name is Leslie Bowles. I am the co-owner and president of Review Healthcare. And today I will be presenting on the new 2025 CPT coding and regulatory updates for the upcoming year. So this presentation will allow you to navigate through them with confidence after today. Just a little bit of background about myself. I am a certified coder, healthcare compliance professional, and my bio goes into some of my background there, so feel free to take a look at that at your convenience. So let's just dive into what our agenda is going to be today. So first, we're going to talk about some objectives, promise, and disclaimers. We're going to give you an overview of all of the coding for the upcoming year, so you get a summary of high-level summary of what the changes are, and then we're going to get into the individual specific specialties and areas, which there's quite a few here that we wanted to share with you. We are going to talk about some Medicare physician fee schedule changes, which is always important. AI, this is a topic that everyone is talking about. And so I'm going to be sharing some updates with you there as well. And then some things for you to think about in the future. Our very last segment of this presentation will be about forward thinking. So I'm excited. So let's first start with the objective. So the objective is to share and learn about significant updates being implemented by the AMA for January 1, 2025. And this session will also cover regulatory updates and enforcement actions as well. All right, just a few disclaimers that we wanted to share with everyone so that everyone knows. This is a high level overview of all of the CPT coding changes and updates for 2025. It's not an all encompassing review. And so, those of you that are listening today are encouraged to go further than the material that's presented herein because. As we know, in an hour, I won't have the ability to cover every single change that's going to be occurring in the new year, but I do want you to know that we will be highlighting on the key ones. The additions and updates to CPT codes are not a guarantee for payment, so you're also encouraged to obtain direct guidance from payers regarding coverage and payment. This is something I say all the time. It's really important when you do hear information from individuals like myself, vendors, speakers, experts in the industry. You do trust but verify, right? We are trusting resources here at Review Healthcare, but for specifics about information related to your region, I think it's important to reference them locally. And then one thing, also know that all of this information is from the American Medical Association. And if you're like me, and you're a coding geek, that means you already have ordered your CPT coding books, and so you may have insight into some of this already. All right, so let's talk about the summary or the overview of changes. So for 2025, there was a total of 420 editorial changes. So this includes 270 additional codes, so new codes, 112 deletions, and 38 revisions. So that brings the total count to 11,321 CPT codes for 2025. So just some fun facts there. Now, also on this slide, we do provide a table it sort of breaks down by the different sections of the CPT book and the type of coding that's available to us, what the additions, deletions, and revisions are, along with the code count for each section. So we're going to go through each one in more detail. One of the things that I did want to highlight, and Markia is on. Markia is our project manager. She is phenomenal. She's also going to be screening the chat just to stop me if there's any questions or anything that anyone wants to add. So we do want to make this as interactive as possible for those of you that are on and listening to the sound of my voice. So please do not hesitate to ask as many questions as needed. All right, so let's get into the first. I think this is a pretty significant change. This is a very interesting one, and this is in regards to telemedicine services. So this is around E&M coding. One thing to note, telephone service codes, which is CPT codes 99441 to 99443. Now, these are considered non-face-to-face service codes. These were what we called audio only codes. These will or have been deleted effective January 1, 2025. And that's also something really important to note. Everything that I'm talking about today is effective January 1. So please keep that in mind. Now, they've been deleted and they have been replaced with these new CPT codes. So we have these new set of categories. The first one, synchronous audio video evaluation and management services. So we now have E&M codes specific to telemedicine that indicate whether it's audio and video or audio only. Okay, so very similar to evaluation and management codes, it is categorized by new and established patients. So if it's a new patient, it's one set of codes, and if it's established patient, it's another set of codes. So you have CPT codes 98000 to 98003. Those are the new CPT codes that you would use for telemedicine visits in which it was delivered both by audio and video, synchronous audio and video E&M. And then for the established patient codes, you have 98004 to 98007. So these are new codes. If you do not have or know about these codes, please write them down, make note of them. I think with the telemedicine service or delivery model sort of expanding, I think it's really important to have these codes and to know them. Now, on the audio only codes, they have been replaced with CPT codes 98008 and 98011. Those are the codes that we would use for new patient when you deliver telemedicine services audio only, E&M. And then 98012 to 98015 is for established patients. So really good information there. It's a change, and these new CPT codes or these additions do not come as a surprise. I had a feeling that there would be new codes to identify these type of specific services, moving us away from the E&M codes with the modifier. Now these specifically indicate in totality the telemedicine service and for both new and established patients. So good information there. In addition, we also have a new CPT code for what we call brief synchronous communication technology service. So if you know anything about this, this became increasingly popular, especially around the pandemic, where this code virtual check-in was utilized. There's a new code for it. So it's CPT code 98016. So good information there. I believe my prediction, this is just the Leslie Bowles prediction, that there will be more to come on this. I think telemedicine is going to become increasingly important. And so we're going to see more and more of these type of codes implemented. So good information there. So what should you know about some of the guidelines related to telemedicine service? So these codes describe real-time interactive encounters between physician or other qualified healthcare professional and the patient. They are similar to the E&M codes that are established for face-to-face, those in-person face-to-face visits. They're based on level of MDM or total time for E&M performed on date of encounter. So this will be great from an education standpoint. It doesn't deviate. There's not a new way of calculating them. They're still in line with what most of our physicians and clinicians and providers are familiar with. We're still using medical decision making and time. They're just specific to telemedicine now. They're not used for routine telecommunications related to a previous encounter. So let's just say you need to communicate lab results to the patient. These are not those. They are not those type of services, right? So that's important to remember. And they may be used for follow-up of previous encounter when follow-up is required. So due to the establishment of these new codes for reporting telemedicine office visits, a very another interesting factor is that we used to have this star symbol in the CPT book to indicate that it was okay, or these were considered appropriate to also be billed via telemedicine or to report them as telemedicine services. Now that we have these telemedicine specific E&M codes, that symbol has been removed from the face-to-face office visits that you see. So 99202 to 99215, and they will no longer be reported for telemedicine office visits. One of the things that I do strongly encourage you to do when it comes to specific payer rules and guidelines is to inquire about whether this is the route that they want you to go when it comes to telemedicine services. So we know that these new codes have been established by the AMA. which is wonderful, but sometimes payers often are late to the party, right? When it comes to updating and determining whether they want to utilize these codes specifically. So I would inquire with payers, federal and commercial alike, just to make sure that these are the codes that they would like you to use for telemedicine services. Sometimes we get excited about these new codes and we don't inquire. So uh, something really important to remember and to note there. All right, so let's talk a little bit about telemedicine expansion. There's a lot going on. There's a lot of movement around it. So pre-COVID, it was restricted. Telemedicine was restricted to rural areas and required in-person visits for telehealth services. And then during COVID, we had this restriction sort of lifted, right? Where there's waived restrictions, telehealth expanded nationally. Then there was also higher reimbursement rates. And now post-COVID, we do see this continuous expansion. Now, I know there's been some updates recently post COVID about what Congress is going to do to avoid it reverting back to pre COVID restrictions. And I believe there's been some updated information to indicate that that expansion decision has been decided upon. But we are, if we are, they do have to make a decision by December 31st, 2025. So if they have not done so, because they could be doing so right now as I'm speaking, but if they have not, we do anticipate that decision coming about before December 31st. And if you are a facility or your organization, your physicians, your providers are providing telemedicine services, you do want to keep your eye on this decision. Okay, so this is really, really important for the year. Okay, so just jumping back to the brief synchronous communication technology service, also known as a virtual check-in, that new CPT code 98016. Just some important things to remember that it is patient initiated. It is what we call a virtual check-in. It is for established patients only. It does not originate from related E&M service from previous 7 days. So when we were providing guidance around this time to clients and others, or even those that use it now, we wanted to make sure that they understood that there are some criteria that you have to follow when it comes to this virtual check-in code. And this is one of them, right? It doesn't originate from a related E&M service from previous 7 days. And it should not lead to an E&M service within the next 24 hours or soonest available appointment. At that time, that CPT code is not considered appropriate to bill. And so therefore you want to make sure that when you're educating on this virtual check-in code, that you reiterate this criteria. It is a part of the code description as well. And so time from 98016 may be added to the time of E&M service for total time when a virtual check-in leads to E&M service on the same calendar date. So let's just say a virtual check-in is performed, but then for whatever reason, the patient needs to come in. That time can be associated with the face-to-face E&M time visit. Now, that doesn't mean you can bill for both services. That just means that that time can be included in that face-to-face E&M visit. So something really important to note there as well when educating. Another really important addition to, I guess, this conversation about E&M coding is advanced primary care management service codes. So this is really important for those of you that are doing or providing services like chronic care management. This may be of interest to you. We're going to talk a little bit more about these codes in just a second. You'll see that there's some new alphanumeric HCPCS codes that have been implemented for the new year. So along with, we've given some estimated, I want to use the word estimated very strongly, estimated reimbursement rates for it as well. Okay, so we've gotten past the E&M section. Let's now move on to pathology and laboratory CPT updates. So pathology and laboratory is always one of those sections where I have never seen a year go by where there are no new changes whatsoever. So this one we did see quite a few changes. There are some new codes, CPT codes that are related to MAAA services along with chemistry services and immunology services. So if you are performing these services in your organization, it's good to take a look at the new diagnostic testing and panels that they have now implemented for the new year. There are also quite a few revised codes here. Well, there's three in particular: PLA and Tier 1 molecular pathology enhancements. And then also for deleted codes, redundant proprietary lab tests have been that are replaced have been removed for the upcoming year. So interesting information there. All right, so let's now move on to urology. Urology. So we have 10 new codes, one surrounding MRIs, transurethral ultrasound ablation of prostate. There are new codes for insertion and treatment codes, CPT codes 51721, 55881, and 55882. Then you have histotripsy of the kidney. There is a new code related to non-thermal ablation of malignant renal tissue. This is CPT code 0888T. Now, for those of you that are familiar with the categories of codes that are out there, this is what we call a category 3 code, a T code, in which the T indicates at the end of the code that it's an emerging technology code, right? So it's one of those new types of services or delivery models for that particular procedure. And so what often happens is a T code will be provided to see who's using it and volume and all of that good stuff. And then more than likely it'll transition to a category 1 code if there is a significant amount of usage there, and sometimes it does not, it's sunsetted. But one of the things is really important to note about emerging technology codes that oftentimes reimbursement is a challenge, right? Because it has not quite reached the stage of category 1, and so reimbursement, sometimes they're non-payable. And so it's really, really important if you're performing these procedures in this manner, this emerging technology codes, it's good to see or inquire about reimbursement, if any, when it comes to the use of T codes. All right, so some other new codes under this section: sympathetic denervation using radio frequency ablation, CPT code 0935T. And then we also have insertion removal and replacement codes related to cystoscopic prostatic urethral scaffold. I hope I am saying that correctly. So CPT codes 0941T, 0942T, and 0943T. All right, we also have some revised codes under urology. So bladder, neck, and prostate procedures, adjustments to descriptions for better clarity. I always love when the AMA and CPT, they update descriptions so that it's more clear for all of us, because it's really hard sometimes when you have vague descriptions. And so providing more clarity is always good. And they did that for CPT code 53865, which is amazing. 4 codes were deleted, and so this is an example. These codes were actually deleted due to low utilization. So CPT codes 50135, 51030, and 54438. And there also was a revision and cleanup code for 51020 as well. So interesting information there. All right, so moving along in the neurology and neural surgery section, there are 7 new codes. Um, Again, you're going to see a lot of emerging technology codes in this section as well. So keep in mind the information I shared about that. So there are codes related to integrated cranial nerve neural stimulation. So we have CPT codes 0908T, and then 0909T, and 0910T, along with 0911T and 0912T. So, if these are procedures that you're performing in your organization, be a good time to take a look to see if you have the appropriate code and description in your CDM. Then there are also new codes related to MRIs, guided high intensity focused ultrasound. So there's a new CPT code 0947T. There's also transcranial Doppler studies, TCD. There's new add-on codes for that. And these are not um, emerging technology codes, but they're category 1. So CPT codes 93896, 93897, and 93898. So really interesting information there. Now, someone had asked a question: how often would you recommend a practice to have a compliance review? This is an amazing question. And I always say that when you're thinking about coding, you want to look at it from 2 different perspectives. You want to look at it from a risk perspective, right? So what is your risk as it relates to those services? Is it high volume? or high dollar. And depending on that, you would sort of let that be your guide. Now, my recommendation is at a minimum annually, at a minimum, right? I do believe, depending on what the services, in what category they fall into, whether it's volume or it's high dollar, because we all know from an audit scrutiny standpoint, it's on their radar, right? So it should be on your radar. And so, depending on the errors that you find, I would increase it. I would increase it to biannually or quarterly. And I've seen with a lot of our clients, we've seen really good examples of that risk-based approach, right? They decide a frequency that is dependent on risk, also resources, and accessibility. That's really, really important to consider as well. And then also looking at things like denials and external audit, including those five factors in to determine, okay, how often should we be looking at a particular area? But minimally, baseline, it's really important to look at certain types of services annually. So I hope that answers your question, Kenneth, and great question. Thank you for asking. All right, so moving on to the next slide under neurology and neurosurgery CPT updates, there's also revision to transcranial Doppler studies, TCD studies. So two codes, 93886 and 93888. We also had some deletions, and this is for MRG FUS. Now, if you were with me in the previous slide,
Hi, Leslie. I think your audio may have gone out.
okay, can everybody hear me okay again now? Yeah?
Yeah, all good.
Okay, wonderful. I was having audio issues. My apologies. So I'll just go back a slide just to make sure that we heard everything that I said before. So um, going back to neurology and neurosurgery CPT updates, there was two revised codes related to transcranial Doppler studies. CPT codes 93886 and 93888. Along with, so this is an example here of a code that was previously identified as a category 3 code, an emerging technology code that was converted to a CPT code, a category 1. So they deleted 0398T. And then for motion analysis, CPT code 96003 is deleted as well. So thank you for bearing with me. Sorry, sometimes we have technology issues. All right, so moving right along, let's talk about ophthalmology. So there are new codes for ophthalmology in the section surrounding photobiomodulation therapy, so CPT code 0936T. There's also new codes related to iris procedures, CPT code 66683. And then there's a new code for OCT, CPT code 92137. So if you are working in the specialty of ophthalmology or an ophthalmology practice, it's really important to note these as well. There are some revisions related to eye movement analysis codes, so CPT code 0615T, also associated with iris procedures, so CPT code 66680 and 66682, along with OCT. One of the questions that I get quite a bit is, why are revised codes important? Because they're not necessarily changing the code. Well, they're important for descriptions and guidelines. This is a really, really, really important factor to consider. Just because the code itself did not change, oftentimes the instructions on how you utilize them will, right? So, and their description. So if you have the description in your CDM or your charge description master in one way, and you don't update it when these new descriptions come along, you could be using them inappropriately. So it's always important to evaluate not just additions and deletions, but also revisions. Are we looking at our revisions of our descriptions in our CDM? So that's a really important part too that I wanted to share there. So within OCT, there's also updated terminology and descriptions for CPT code 92132 and 92134. There are 3 deleted codes, category 3 codes that were replaced by 66683. So CPT code 0616T, 0617T, and 0618T are all deleted under iris procedures. I'm just checking the chat, making sure I don't miss any questions. All right, so digital medicine. This is a new, very exciting um, area within medicine that has just sort of taken off in the last, I would say, 10 years. So interesting, we've got quite a few changes here. New codes related to remote therapeutic monitoring, so RTM, related to setup and education, device supply, treatment management services. There's quite a few codes there. So CPT code 98975, and then they do have new codes depending on the system, whether it's respiratory system, it's CPT code 98976. Then you have your musculoskeletal system, CPT code 98977, and then cognitive behavioral therapy, CPT code 98978. Then we also have our treatment management services. So first 20 minutes, these are time-based codes, so always something important to remember and consider. 98980, and then you have your each additional 20 minutes, 98981. There's also new codes for AI-based QT interval monitoring, so CPT code 0902T. Then you have algorithm-based ECGs, very interesting. CPT codes 0903T. That's the full service that includes recording, interpretation, and report. For tracing only, you have CPT code 0904T, and then your interpretation and report only is CPT code 0905T. Okay, so very exciting there. We also have new codes related to AI assisted heart failure detection. So what I think this AI or these procedures that include AI, you're just going to continue to see more and more codes developed for procedural coding. So it's something to keep your eye on. But these are all emerging technology codes, category 3 codes ending with a T. You have 0932T for AI assisted heart failure detection. Then you have non invasive AI analysis for chest CT data. So this is CPT code 0877T, 0878T, 0879T, and then you have 0880T for this category. Then there's AI generated prostate cancer mapping. There's a new CPT code for that, 0898T, along with computer aided duplex scan of hemodialysis fistula. So CPT code 0876T. It's quite a mouthful there. All right, moving along to the next section. Under digital medicine, we also have some revisions related to RTM services. So there's been updated definitions and exclusions for CPT codes 98975 to 98981. And there's also parenthetical notes that were updated for duplex scans. So updated exclusions for CPT code 76376, 76377, and 93990 to prevent overlap with new codes. So if these are procedures that you are performing in your organization, it's really important information to notate. All right, we've reached surgery. Let's talk about general surgery. So there are 23 new codes. That doesn't shock me at all. There's always a good amount of revisions, deletions, and additions in this section. There are new codes related to skin cell suspension autograft, so SCSA. We love acronyms in healthcare, so that is the acronym for that procedure. CPT codes 15011 to 15018. There's also new codes related to intra-abdominal tumor excisions and destruction, CBT codes 49186 to 49190. Endoscopic drug-coated GI balloon, CPT code 0884T to 0886T. So these are emerging technology codes. There are also two new revised codes. They're associated with updates to autograft and tumor excision descriptions. And there are deleted codes. There's six. So we have 26132, 47802, 49203, and then also to 49205, and then 58957 as well. All right. So orthopedic surgery. We have four new codes, one related to hand, wrist, and forearm repair or reconstruction. So you have your arthroplasty code there, CPT code 25448. There's also a new code for bone substitute injection, CPT code 0869T. Then intraoperative stimulation of peripheral nerves, CPT code 0882T, and CPT code 0883T. There is a revised codes also in the hand, wrist, and forearm repair or reconstruction section specifically for CPT code 25447. There are no deleted codes for orthopedic surgery at all. All right, moving to the next slide. Under anesthesiology and pain management, there are eight new codes, one related to end tidal control monitoring, CPT code 0887T, and then fascial plane blocks. There are quite a few codes there, CPT code 64466 to 64469. We also have 64473, 64474, and then 64486 to 64489. So those range of codes are new codes added to this section. Two new revisions related to block technique updates also in this section, and no deleted codes. Now, medicine is also another section from a primary care perspective where you see quite a few changes, additions, and deletions always year to year. So there's new codes related to immunization codes. You'll see there for mRNA, influenza vaccine, CPT codes 90637 and 90638. We also have some new immunization codes related to pneumococcal. So that's CPT code 90684. And then the avian flu vaccine, CPT code 90695. It's really important to note for this section that we are starting to see more and more CPT codes being developed based off of the type of vaccine it is, including the substance that is within the vaccine or the type of flu rather. And then also even the brand. So it's really important for your coders or for whoever's coding, whether it's your physician, your coders, generally it's one or two of them or your providers to know the difference between the two and making sure that it aligns with the type of vaccine that you're purchasing in your organization. So really important there. There are revised codes. We talked about this a little bit earlier with modifier 95, the telemedicine modifier that we use. So now with the implementation of these new telemedicine codes that are now out there, modifier 95 and the instructions surrounding it for face-to-face E&M visits will transition, right? Now we will focus solely on those telemedicine codes. And we no longer need the modifier 95 to report it as a telemedicine service. So interesting information there. And there is a deleted code related to obsolete vaccine products under this section as well. All right. So now we're in the world of cardiology. Cardiology and interventional cardiology CPT updates, quite a few. We have 26 new codes, some of them related to angioplasty of the aorta. So if these are procedures that you're performing, it's a good time to take a look. CPT codes 33894 and 33895, along with 33897. There's also a new code related to pulmonary gas exchange analysis, CPT code 0893T. Then you have non-invasive arrhythmia analysis services, CPT code 0897T. You have CMR, which is CPT codes 0899T to 0900T. Then you have percutaneous coronary intervention, PCI by drug delivery. Those are CPT codes 0913T and 0914T, along with CCMD procedures, which is cardiac contractility modulation defibrillation. That's a mouthful. CPT code 0915T to 0931T. So new codes there. There were four revised codes. So angioplasty of the aorta, CPT codes 33894, 33895, and 33897. Also atrial fibrillation ablation, CPT code 93656 was also revised. Three deleted codes in this section. So pulmonary valve, CPT code 33471. Your atrial septectomy, open heart procedure, CPT code 33737. And then also obliteration of pulmonary defect without bypass, CPT code 33813. So quite a few changes there in the cardiology section to consider, and interventional cardiology. Radiology and interventional radiology. So we have 12 new codes in this section. MR safety procedures, MR safety planning and procedure codes. These are new codes, CPT code 76014 to 76019. We also have percutaneous RF ablation of the thyroid. That's a new code there. CPT code 60660. There's also a new code to identify additional thyroid lobe ablation. So that's CPT code 60661. There's a new code for bone marrow biopsy implant, CPT code 0901T. There's a new code for percutaneous ablation treatment services, CPT code 0944T. And then CT guided implant movement analysis, CPT code 0946T is also a part of the new codes for this section. As far as revisions, there's one revision related to vascular procedures under the subsection guidelines. Really important. This is another example of why not just looking at deleted or added codes, new codes or deleted codes, is important to evaluate guidelines as well. So there's new updated guidelines for angiography procedures, CPT code 75774, and there are no deleted codes in this section. All right, so now let's get to the fun stuff. Let's talk about what new Medicare physician payment schedule changes are out there that you should be aware of. So some of them are around conversion factor changes. This is always of interest to many, many physician practices and hospital with physician services. So the 2025 conversion factor is set at $32.35, which is a decrease of 94 cents from 2024. So this reflects a 2.93% reduction in payment rates due to expiration of temporary increases. So something to be mindful of and keep your eye on as well. Telehealth services, we did talk about telehealth quite a bit, but there are new additions to Medicare telehealth services list, including caregiver training and PREP counseling. There now is a permanent allowance for audio only telehealth in specific scenarios, which I know is beneficial to a lot of organizations to have that allowance for use of audio only. So really, really important. Virtual supervision finalized for certain services through real-time telecommunications. I will tell you from a compliance perspective, it's really, really important to ensure that you know which type of telehealth services will allow virtual supervision. So, really important there. E&M, as far as Medicare physician payment schedule changes, we did talk about quite a bit, but they did finalize the use of G2211. There's a lot of conversation around this add-on code that is related to office visits. So this identifies complexity when paired with preventative services. There is a new HCPCS code for infectious disease management and inpatient and observation settings. And then advanced primary care management, I touched on it in the E&M section, but these are three new codes that really they're services for chronic condition management, varying by complexity and qualified Medicare beneficiary status. So these services are particular to chronic condition management. We are starting to see more and more each year new codes being developed as it relates to chronic conditions. So if this is of interest, I would really encourage looking at the documentation requirements and the overall criteria for use of these codes as well, because this can also be a revenue opportunity for some organizations. All right, so some new policies to consider. Global surgery payment accuracy. So they brought in the use of transfer of care modifiers 54 and 90-day global surgical packages. There's a new add-on code, G0559. And normally Medicare is the one creating these what we call alphanumeric codes, these HCPCS codes for post-operative care provided by different practitioners. So really important information for Medicare beneficiaries. For dental services, there's expanded coverage for medically necessary dental exams related to dialysis and other linked conditions. We saw the start of this last year with the expansion of dental services and the coverage as far as medical necessity goes. So we're continuing to see that in 2025. There's also the required use of the KX modifier and diagnosis code starting in July. So this is what I always tell all of our clients, just in general, from an education standpoint, whenever we receive these new changes in the beginning of the year, they just don't happen January 1. There's also numerous changes that happen throughout the year. So it's really important to keep your eye from a regulatory standpoint on what's happening so that you're aware and you know when to implement and when these new changes become effective, because not all of them are always January 1. As far as behavioral health services go, there are new safety planning G code for crisis interventions in 20-minute increments, inclusion of digital mental health devices under Medicare with three new codes, caregiver training services. Again, new codes that were implemented, but now we're starting to see an increase in the specialties that they are allowed. So new codes for caregiver education on wound care, behavior management, and other skills. And then opioid treatment programs, there's a permanent flexibility for audio only telehealth, and there's new payment codes for FDA approved opioid medications like nalmefene. I might be saying that incorrectly. My apologies, but new information there for the Medicare physician payment schedule. And then updated coverage. So colorectal cancer screening. So this is expanded to include CT, colonography, and blood-based biomarker tests as well. And then they remove coverage for barium enemas. So really important information there. Physical and occupational therapy supervision. General supervision is allowed for therapy assistants in private practices. This is an interesting one. I was actually shocked that we moved from direct supervision to general. So, really interesting information. I would also, for all of our rehab facilities and practices, I would take a look at what your local Medicare administrative contractor is also stating about general supervision for therapy assistance as well. So, compare, make sure you look at the federal, but also look at what's local to your region as well. AI and the CPT code set. There was a time where I said coding in AI is probably going to take a while, but it didn't. There is a whole new appendix s- totally for AI. So CPT Appendix S. If you ever look at the CPT book, there are a lot of different appendices in the back, and there's one specifically for the AI taxonomy code. And now AI services are categorized into the three different types. So assistive, augmentative, and autonomous. So it's a really good time to take a look to see which CPT codes include AI and if you're using them appropriately. Just some examples of assistive ECG risk assessment. Then you have the AI-based fractional flow reserve. Then you have retinal imaging with AI interpretation, sort of categorizing those three as examples. And then it focuses on aligning AI classification with the physician work to streamline coding, valuation, and payment. We are going to continue to see this become a factor as we move on, and AI is implemented more and more into healthcare, and we have different types of technology that continues to advance. So I would definitely keep my eye on how descriptions are changing based off of the types of AI that are being utilized for those procedures or services or diagnostic testing. You're going to see descriptions shifting more and more to include AI so that it's accurate when it comes to the way in which we code for those services. All right, so just rounding out here, and thank you so much for those of you that have put comments into the chat. We greatly appreciate it. Just makes the session more lively. And I apologize for my technical difficulty that we had there, but we were able to resolve it really quickly. But just some things to think about forward wise. You want to make sure you train and educate your team. This is something that I did when I was working in the hospital setting prior to working in private equity and then and starting my own firm. One of the things that we always did is, in addition to gaining all this information about all of the changes that were coming about every year, we actually created an education plan around it. Now, that doesn't mean we sat down and did this presentation in totality with every single department. No, we sort of picked it apart, said, okay, what procedures are applicable to our facility, our department, volume wise, risk based, and who do we need to educate? So I would strongly encourage you, if you haven't done that, it's not too late to take a look to see who would benefit in your organization from getting this information. It always contributes to compliant coding and accurate coding, and it contributes to the model that I have. You want to make sure that the revenue that you are billing for, you can actually keep, right? By accurately coding and making sure you're keeping up with all of the updates. Another really important aspect to do with this information is to update your documentation and systems. It's really nice to sit down with your charge description master folks or your folks that govern over these coding changes, no matter what department they're in or what area they're in or what type of facility, to make sure that your documentation or your systems are updated. That also includes third-party vendors, right? Third-party vendors that you utilize. Ask them, how often do you update coding updates? Are the new updates in there? Does that include just additions and deletions? That does also include revisions. What about guidelines that affect the way that we bill for these services? So it's a really important part there, making sure that you update your documentation and systems, but also sending in inquiries to your third party vendors to make sure that they too are implementing their systems. And then adapting operational processes, create workflows to manage new codes, especially time-based or overlapping services. You also may want to think about adding it to your audit plan. If you have a coding compliance or revenue integrity or your compliance department or just an outside party that helps you with coding audits, you may want to include that to make sure that you're utilizing the codes correctly and all of the modifiers or new changes or new revisions. And then focus on revenue opportunities. I'm a compliance professional, and sometimes saying that is like taboo. But if the code is there, right, and if you are performing the service, and it is documented and the medical necessity is there and you have the opportunity to now bill for that service, why not focus in on it? Make that a sole focus. If you saw any new or services that you were not previously billing for that you can now bill for, create a plan around it. Make sure you're monitoring it and having a plan to audit it, train and educate, and receive reimbursement for it. There is nothing wrong with that. Engage with your payers. This is really, really important. We talked about this quite a bit. It's just as part of our disclaimer that not all of the CPT code changes that are implemented by the AMA are always automatically adopted by the payers. And then sometimes they may not be adopted at all. So you want to reach out to your payers, especially if you have a high volume. I think all of us should be inquiring with all of our commercial payers and even Medicare or local Medicare administrative contractors on those new telemedicine E&M codes. Those are brand spanking new, and it changes the way we bill for telemedicine. So that's just a good area to focus on. And then fostering innovation, coming up with new processes and using tools and AI to kind of assist is also good if you have that opportunity. If not, you can ignore this particular recommendation. All right, so these are my references for today's presentation, and I am going to open it up now. If there are any questions, comments, again, here at Review, we thank you so much for spending time with us to go through. This is always not the most exciting set of information to go through when it comes to the new CPT coding, but we do appreciate you sitting through and learning all about the new coding for the new year. So, Marquia, I'll turn it over to you. Do you see any questions or comments in the chat?
No, not at this time.
Okay. Wonderful. That's a good thing. That means we went through the material really well. So thank you all again. I hope you all enjoy the rest of your day. And please, please, please follow us on LinkedIn, Review Healthcare, our website, www.reviewhealthcare.com, and just stay in touch with us and connected for our next set of webinar series. Thank you, everyone.